All right, so good morning, everyone. My name is Joe Neglia. I'm the chair of the Department of Pediatrics, and get to introduce the program today. This is a special program, a special Grand Rounds, because at this Grand Rounds, we are going to award the 2017 Gold-Headed Cane to Dr. Young-Ki Kim. And this is the single greatest honor that this Department of Pediatrics can bestow upon a pediatrician in our community. It's not limited to faculty members. It's been given to pediatricians, several pediatricians in our community, as well as many of the faculty, but really recognizes a lifetime of excellence in the care of children, and excellence and contribution. And you'll hear more about Dr. Kim today and how he accomplished that over his career. So again, we're excited to be here. It's been great to watch this event grow over the years. This is our first time doing it in conjunction with Grand Rounds, so if it gets a little rough, give us a break. I really do want to thank everybody for attending. We have a number of our past faculty here, many past deans here, maybe they have a job in store for them here in the next few weeks. We've been doing this event now for 9 years, and it's been very, very good for all of us. The Department of Pediatrics, really based on the work that so many of our former faculty have done, has remained strong. This year we slipped to 16th in the NIH standings because of the loss of the CTSA grant. As most of you have heard, that grant has a fundable score, and we're anxiously awaiting the notice of that grant award early next year. For the 10th consecutive year now, our Children's Hospital has been ranked among the best children's hospital in the nation by U.S. News & World Report, this year in 4 specialties, including diabetes and endocrinology, gastroenterology, neonatology, and pulmonary. And nephrology, is it 5? 5 this year, sorry. Thank you, Michelle. This would have been really bad to miss that, and when we were giving this to a nephrologist. Actually, nephrology has probably been the most, nephrology and neo are probably the 2 consistent ones over the years. Training programs continue to be strong. We're continuing to train over 2/3 of the pediatricians for the state of Minnesota and about 80% of the subspecialists. And these programs have been augmented over the past few years through the work of our education leadership with grants from the Minnesota State Department of Health, the International Immigrant Physician Program, the Primary Care Expansion Grant, and the signature program here right now, the Education in Pediatrics Across the Continuum. So a lot of great work going on in education as well. We have now been in this building for over 6 years. Last year was our 5-year anniversary of moving from the East Bank over here to the West Bank, and we've been able to grow in many ways with a great deal of help from our philanthropic partners. So just over the past year, we have opened the Blythe Brendan Mann Wellness Center up on the 5th floor. This is a space dedicated to providing parents and caregivers with access to fitness equipment, some integrative therapies, as well as salon services for the families and the kids, so not for the faculty. In a few months, we're just around the corner here, we'll open up the Kyle Rudolph End Zone. Kyle Rudolph is one of the Minnesota Vikings. He's taken on the challenge of raising money to support a space that is going to be dedicated to our adolescent young adult population, where they'll have a chance to play, relax, and engage in healing therapies. We've had new adopter rooms built out. We have a new program in the pediatric ICU in conjunction with Philips, which is a lighting system that hopefully will lead to improved circadian rhythms for the kids. So many, many things going on. I'd like to just comment quickly on a few recent gifts. Recently, a $250,000 gift from the Moody Glaser Foundation for the International Adoption Medicine Clinic, and a gift of $500,000 from the Catherine B. Anderson Foundation to support cardiac surgery. Also want to recognize the Hubbard family and Hubbard Broadcasting Foundation for a gift of $250,000 that will support pediatric simulation training, the ICU, adopt-a-room, and pediatric resident education. So philanthropy of all sizes really makes a difference for what we do here. I do also want to recognize the passing of two former recipients of this gold-headed cane, Dr. Forrest Adams, and Dr. Arnie Anderson. So we thank them for all they did for this department over the years. All right. Oops. Sorry. So today we have the opportunity to recognize our friend and esteemed colleague, Dr. Young-Ki Kim. Dr. Kim is a 2017 Gold-Headed Cane Award recipient and recognizes a lifetime of service. Since 1972, this award has gone to members of the community that have demonstrated outstanding service in pediatrics. The gold-headed cane is emblematic of excellence in medicine. And if you go back to the history of the Gold-Headed Cane Awards, it really is a legacy award, a gift from one generation to another that developed originally in Great Britain, essentially recognizing outstanding clinical skills, outstanding service to the medical community. And we're very fortunate to be able to give that to Dr. Young-Ki Kim today. We have a number of former Gold-Headed Cane Award recipients here with us today. They include Dr. David Brown, who is somewhere in here, David, Dr. Paul Quee, Dr. Al Michael, Ed Kaplan, Dr. Moeller, Dr. Joe Sokolowski. And did I miss anybody? I don't think so. So thank you all for being here. I also want to recognize the Gold-Headed Cane nominating committee. This includes Dr. Aaron Friedman, Paul Quee, Norma Ramsey, Al Michael, Mark Nesbitt, Abe Jacob, and John Andrews. So at this point in time, we'd like to begin the presentation, first with some remarks from Dr. Al Michael. So Al.
Well, I'm delighted to be here, and it's a great department of pediatrics. And so I'm going to kick this off. Mike Maurer has a lot of discrete information, and he'll be following me, so I'll be relatively brief. In 1971, 46 years ago, I got a call from Saul Krugman, who was at that time head of the Department of Pediatrics at New York University. And I can still remember the conversation. He said, you know, I have an outstanding resident. And oh, incidentally, he took the pediatric boards and became first in the nation. Now, that's not information that's usually passed out to the public. But Saul had some information, and I perked up my ears. And to make a long story short, he came to Minnesota, where Bob Vernier and I were beginning work, and had begun work in the late 60s in pediatric nephrology. Young-Ki Kim then received, had come from training in Germany, at Göttingen, Germany, and also in South Korea, and had proceeded then to NYU as an outstanding family, which I had a great opportunity to visit with many years ago, including 6 siblings, who were among the leaders in medicine and music and law in Korea. So it was interesting to observe Young-Ki during those early years through his fellowship and during the subsequent period of time. So 46 years ago is a pretty long time. And so Young-Ki proceeded to be one of the outstanding teachers of the University of Minnesota. Observing him, he had a unique ability to interact with students. I had an opportunity during those years to watch him teach. He stood out as the most effective teacher. And as I stand here now, reminded of others who were involved in education and with respect to specifically William Osler, who in the 1890s had helped develop with 5 other physicians John Hopkins medicine at the time. And Osler came to be recognized, and still is, as a fantastic physician, but his contributions really, I think, were connected with education. And he was the first to start a residency program in the United States, which a fire that ignited across the country and all parts of the world. So it's now an integral part of medical education. And the other major achievement of Osler was he brought medical students into the wards of the hospital and spoke eloquently about the importance of medical education in the clinics. And of course, this is where Youngkie Kim did so very, very well during the years that he has been here at the University of Minnesota. So I've always thought that one of the great characteristics of a teacher is the ability to excite the student. And Youngkie excites the student in major ways. And I think it's the tribute from today for him, the gold-headed cane, is so very, very appropriate. So I make my words for Youngkie and for Young Sun, who joined him after he had come to Minnesota in '71. And it's indeed a pleasure and a joy for me to make these comments. And thank you very much.
Thank you, Dr. Michael. For those of you who do not know Al is former chair of this department and also a former dean of our medical school. So we got lots of younger faces here now, which is good. So Dr. Maurer is professor of pediatrics and pediatric nephrologist.
Well, it's a special pleasure for me to talk about my friend and colleague for over 4 decades. I'll give you some chronology, a little bit that Dr. Michael introduced. Youngkie graduated in 1964 from Seoul National University, where he did an internship in pediatrics in Germany in 1965. In 1966 to 69, he did an internship and residency at Brooklyn Jewish Hospital, which accounts for his distinct accent. And in 1969 to 71, he then completed his residency, became chief resident and a teaching assistant at New York University that Al Michael alluded to. He came here in 1971 as a fellow in a pediatric nephrology training program and finished that program in 1975. And here you see Dr. Kim in 1971, along with his mentors, Al Michael and Bob Vernier. Then in 1975, he joined the faculty of pediatrics and pediatric nephrology group. In 1980, he was promoted to associate professor. In 1989, he was promoted to professor of pediatrics. And in 1993, you can see him beginning to look professorial. In 1997, he became the co-director of the Pediatric Nephrology Division, a position which he maintained until 2009. He did accrue some teaching awards. The Pediatric House Officer's Outstanding Educator Award, first in 1984 and 85, 85 and 86, 88 and 89, 89 and 90, 92 and 93, and at that point he was designated a University of Minnesota Medical School Master Teacher. He then got the Best Teacher Award in the Department of Pediatrics in 93 and 94, 94, 95, 95, 96, 96, 97, 97, 98, and finally the department gave up. And after these 10 unprecedented awards in 14 years, they developed the Yankee Kim Excellence in Teaching Award so that somebody else in the department might have a shot. And then in 1995, the university recognized him as an outstanding teacher, and he got the award for outstanding contributions to post-baccalaureate graduate and professional education. But he was more than a teacher. He was also, and remains a scientist. He authored 193 scientific papers. He was an investigator in multiple NIH grants, and we were co-investigators in some of those grants, and I can tell you it was much easier to get reviewed by NIH than Yankee. For many years, he directed the immunofluorescent microscopy laboratory at the University of Minnesota. He provided superb pathologic diagnostic services throughout the medical school with the development of a superb laboratory. But he also used this lab as a world-renowned platform for clinical and basic research. So he merged his patient care with his clinical research in an extremely productive way. He mentored numerous fellows in pediatric nephrology, in internal medicine, in veterinary medicine, in science. They learned facts from Yankee, but more important, they learned critical thinking. And as a clinician teacher, he trained dozens of pediatric and internal medicine nephrology fellows in clinical nephrology. To them, he was simply known as the guru. And he still, if you go to the American Society of Nephrology, and I meet one of our former fellows, they ask me, how's the guru? He is also known as the guru to the pediatric nephrology and internal medicine nephrology faculties. He continues his role as an unpaid volunteer in his so-called retirement in 2017. So people come to him with complicated patient care problems. And I would encourage the residents in the audience who've never had a chance to meet a master teacher. Come up with a question in pediatric nephrology. Go up to the 6th floor where Yankee sits and ask him the question and learn what it's like to sit with a master teacher. As a clinician teacher, he trained a cohort of Korean fellows in pediatric nephrology. They now refer to themselves as the Korean Pediatric Nephrology Minnesota Mafia. And you can see some of them here, along with a woman in the center from China, that are reflective of the trainees that were attracted from across the world to the University of Minnesota to study with him. And you can see him here in 2014 at the Korean Society of Pediatric Nephrology, along with a number of his trainees. You'll notice that he's sitting front and center, and the only one that doesn't require a name tag in that group. As a teacher, it's an astonishing breadth of knowledge. He imparted information to his students in organized and logical formats. He was enthusiastic. Most important, he taught them how to be effective learners for the rest of their lives. And that was the gift to the students that he touched. That's why they kept voting for him. Finally, he was and is a magnificent doctor. He provided outstanding care to his patients. He treated his patients and their families with respect and compassion. In summary, Youngkie Kim is an absolutely outstanding recipient of the Gold-Headed Cane Award for 2017. And his wife, who is with him today, was a great part of the strength that Youngkie brought to this institution. It was a joy for me for the last 46 years to be his friend and colleague. Thank you.
Thank you, Mike. I think you've heard, a description of a career that meets the level of outstanding by any stretch. As a person who was a fellow here and a faculty member, it was always a real joy to get a consult and have Dr. Kim do the consult, because you actually knew you were going to get the answer. It may not have been a nephrology answer, but Youngkie was going to help get you to the answer. So this time we would like to invite Dr. Kim up for the presentation of the Gold-Headed Cane Award. Do you have any remarks? So Mike and Al, if you'd come up. Dr. Michael and Dr. Maurer, if you'd come up to present the award with you. I think it would be most fitting for you and Mike to give it. Dr. Kim, congratulations. It goes well. It goes well. All right. So now we're going to start the grand rounds part, and this is also especially an honor to have Dr. Mark Rosenberg here to do pediatric grand rounds. Dr. Rosenberg is the Vice Dean of Education in the School of Medicine. He's a professor of medicine in the Division of Nephrology, and his leadership and innovation here have really formed the backbone of our educational mission over many, many years. So Dr. Rosenberg, thank you.
Well, good morning. It's an honor and a delight for me to be here, and special congratulations from me to Dr. Kim. I trained here as an adult nephrologist and continue to practice adult nephrology. And I can tell you that Youngkie never cared who was on the other end of the microscope. He would teach us whether we were pediatricians or adults or anybody. And one of the immunofluorescent panels from one of his papers, I think it's laminin chain shown here, And so he's had a huge impact not only on pediatricians, but on many of us in adult nephrology, and most importantly on the patients that we treat. It's also an honor to be here, to see my friends, current and former in pediatric nephrology. I think it's always been a very nice relationship between adult and pediatric nephrology, and one that continues, to this day. Yonke still comes to our clinical conference in adult nephrology every Tuesday at noon and continues to teach all of us. And it's also a delight, because I think some of the best educators in the medical school are from the Department of Pediatrics, and I won't name them other than to say John Andrews, who is our Associate Dean for Graduate Medical Education. But some of the best and most innovative people are here in your department. So conflict of interest, my main conflict of interest is I fell in love with the kidney, and it continues to be a relationship that's deepened over the years. And so I'm heavily biased by anything nephrology. So I'm going to just go through some of the more innovative aspects of the things we're trying to do, just to give you a little flavor of what's going on in medical education and what we're thinking about in terms of the future. Including some individualized pathways into medical school, a little bit about competency-based medical education, of which the EPAC program here in pediatrics is sort of the shining example. A little bit about assessing the quality of medical education, and then assessing lifelong competence. So medical school remains very popular. These are the number of applications to medical school, the number of applicants. It has continued to grow nationally over the years. I think the total number of applications since people apply to multiple programs was 830,000. For the University of Minnesota, our applications have been growing, and this year we're now over 5,000 applications to seat a class of 175 on the Twin Cities campus, and 63 start on the Duluth campus. They have another 1,200 applications to their program. We're very proud of the fact that we have increased the number of underrepresented in medicine students from historically about 9% to close to 19 and 20% most recently. So I wish I've gone to medical school instead of law school. The genie says I get a lot of that. So it's still a very popular profession, and the applicant pool, if anyone who's had a chance to work with these students or to interview these students, is absolutely amazing. So there's a number of ways across the world to get into medical school, and these were nicely summarized in this article from a few years ago, but most places around the world, you get into medical school right after high school. The red boxed area is getting into is the way the system is in the United States, in Canada as well, where you have to get a bachelor's degree first, and then you get into medical school. I'd say that it's that way in most places across the United States. The countries where you get admitted to medical school after high school, some of them have more pyramid systems where not everyone makes it to the end of medical school. But it takes a long time, and our graduates, our average age of our incoming class is, this past year, is 24. Many have done a few years after their undergraduate degree before they've applied to medical school. And, we felt that this was a disadvantage to applicants who knew exactly what they wanted to do at a very young age. And again, not for everyone, but we've started this past year this BA to MD program. If the traditional route is shown on the top, 4 years of undergraduate, get your bachelor degree and then start medical school, we now have a pilot program this year where it's done in collaboration with our College of Liberal Arts. They were the ones that wanted to collaborate with us. Interestingly, the College of Biological Sciences did not want to take part in this, but we're admitting, and it's a cohort of 10 students right out of high school, and we're giving them a medical school spot, but they have to fulfill certain criteria along the way, including some credit courses on becoming a doctor. They still have to do their MCAT examination, and they go through a very intensive counseling program. And so the first year of medical school for these students counts as the last year of their bachelor degree. So they'll graduate with a BA, MD degree. And, this was, the goal of this program was a couple of things. One was for someone who knew what they wanted to do to get them through medical school and to the graduation earlier, but this is also focused on diversity, defined in a number of different ways, whether it's underrepresented in medicine, rural, first to school, socioeconomic diversity as well. First cohort of students is shown here, and it's a group of 10. They started their undergraduate program in September, and they meet as a group with faculty mentors on a regular basis as we try to get them ready for medical school. It's interesting, one of them got a special scholarship, and on the left is Taisha, who runs this program, and Goldie Gopher is in the middle, and they came to the student's house and presented her with her admission to medical school and her scholarship, and the band even came with them to welcome her. So competency-based medical education. On the top is the more traditional model of medical education where a very well-developed curriculum is formed, and that drives what the educational objectives are, and then that drives what kind of assessment. But I think since the late 90s, there has been this movement towards competency-based medical education. And, explained simply, the first step is assessing what the health needs are and what the health system needs are. And based on that, the competencies or the outcomes you want to achieve are defined. And once those are defined, then the curriculum gets defined, and assessment is a critical part of this. And assessment really is more direct observation than anything else. And I think there's been this growing movement to this outcomes-based aspect of medical education. And so the paradigm is shifting from this idea of a fixed amount of time, 4 years of medical school with a variable outcome, what our students end up with, we think is pretty good, but it could vary a fair amount among students, to a paradigm where the outcome is really what's defined, and however long it takes to get to that outcome is the length of training. One of the leaders in competency-based medical education is Bob Englander, who we were fortunate enough to recruit here to be our Associate Dean for Undergraduate Medical Education, the principal of the medical school, about 1.5 years ago, and is really a key person in terms of our journey to more competency-based medical education. So what are the outcomes? The outcomes have been nationally defined and are called entrustable professional activities, but stated simply, it's things like, can you do a history and physical? Can you form a differential diagnosis? can you order and interpret diagnostic tests? And there's 13 core EPAs that have been defined through national consensus, and these are the outcomes that we're looking for to have students be ready to advance to residency. The other aspect of this is this change in the model of clinical education. On the top is the traditional block clerkships, where students spend a certain amount of time in each of the different specialties, and then at the end, they can go on to more elective specialty aspects of training. I think the model that we're moving to is this longitudinal integrated clerkship model, where students do a number of the clerkships simultaneously, and it's really driven by the patient panel that they follow. So they may see a patient in the emergency room, follow them to the OR, where they have their acute cholecystitis treated with surgery, see them back, on the surgical wards. They may see them in primary care clinic, and they're really progressing through all of these clerkships at the same time. The most established model of an LIC is our RPAP program, Rural Physician Associate Program, where students have spent 9 months in a rural setting in a given practice, in a given community. And it's now in its 45th year. But the beauty of these LICs, and EPAC, the one here in the department is an example, is the relationships the students develop with the faculty allow the faculty to really effectively evaluate and know when they've reached a point of entrustment, that they can reach and perform these outcomes. But the students also develop a relationship with the health system. They're there for 9 months. They participate in a quality improvement project, usually as part of the health system. And most importantly, they develop a really close relationship with patients and really are a value add to the patients. And we've heard many stories of how a patient won't have that thyroid nodule biopsied or, have this procedure done until they check with their student. And I think that relationship has really become special. We have a number of these programs now, including the RPAP program. We have one focused on urban underserved. We have one at our VA hospital that's focused on quality improvement and patient safety, and one that just started at Hennepin County focused on urban underserved. And then the program here, the Education in Pediatrics Across the Continuum, is really a special program. And in that, it's really the first example and the first test of competency-based progression. So the students in this program become pediatric residents in your department after they've been shown to be entrustable on those 13 core EPAs. And this is an older slide, but it's just to give you a feel of some of the data that's collected on these students. These are an example of 8 of the EPAs, and the lines you're seeing is really the progress of the students in the different outcomes that are expected of them. And this is really based on hundreds of observations of the students by faculty, as opposed to sort of the traditional block rotation where it may be just 1 or 2 evaluations of the students. And so you as faculty really get a good chance to evaluate and tell the students when they've hit that point. Lots of other advantages of this kind of model, but it really has gained worldwide attention, as an example and probably the truest and first example of progression based on outcomes. This concept of fixed outcomes but variable time. And all the people involved in this program should be congratulated. So one of the first things that happened when I came here is the medical school was going through a strategic plan, and we met with the strategic planning committee, and they asked us, how do you know you're doing a good job with medical education? And so we thought of all these things that we could use to judge medical education. Well, we had USMLE exam scores and course grades, and, we followed how many got their first 3 choices to residency. There's in-training exams in graduate medical education. There's CME credits. There's examples of practice improvement. But really, all of these are surrogate endpoints, because I think what we're really trying to do is, be able to assess the effectiveness of medical education by the quality of care our graduates deliver once they leave here. And sort of related to this is we should be able to design medical education to improve care. The best example of this is this paper, and it's a paper where they ask the question, does it matter where you trained in terms of the quality of care you deliver once you leave your training program? This looked at an obstetrics complication database, and so it was maternal complications of delivery. And let me take you through, if you focus just on the top left graph, the 2 lines, the top line is, the graduates of programs where the faculty in those programs had a very low complication rate with maternal delivery, and they divided the programs into sort of 5 quintiles of how good the faculty were in that program. The bottom line is graduates of residency programs that were at the lower quintile. And what this shows is that if you trained at a program where your faculty and your health system had a low maternal complication rate, when you went into practice, you also had a low complication rate. So it did matter where you trained. And, this is, something that's had a huge impact on the way I think about medical education. Interestingly, another thing they did, again, focusing on the top graph, is they asked the question, does it matter how long it's been since your residency program, in terms of how good you are? And so again, obstetrics complication rate, and what it shows is the longer you've been in practice, the lower your complication rate, even going out, to 20 or 25 years. So experience matters. You could say that, well, these are obstetricians who've learned to avoid the highest complication cases, but they try to control for this. So we've been trying to reproduce this approach to medical education, and just recently we've had this soft launch of what we're calling a medical education outcome center, where we've collected, probably over 90 sources of data on medical education, on pre-medical school criteria, on medical school criteria, and we've been trying to link it with different clinical outcome databases to try and, among other things, see what kind of care our graduates deliver. Lots of problems and complications doing this, and including many of patient outcomes, are more attributed to the system or the other health professionals that work, but it really changes the culture of how we think about medical education, directed at, how good are our graduates once they leave us. So let me finish with a little bit about assessing lifelong competence. The medical education continuum is long, but the majority of our time is spent in practice. And, so how do we assess, whether a doctor who's been in practice for 5 or 10 or 15 or 20 years continues to deliver, high quality medical care? So we're regulated a lot in medicine at every level, UME, GME, and practice. Lots of different examining and accrediting bodies. I'm going to focus just on this whole idea of recertification and lifelong competence, which really is controlled by the American Board of Medical Specialties, of which the American Board of Pediatrics is one of the 24 specialties. And, these are the organizations that give us our initial certification credit, but also are the ones that recertify us. So nowadays, in each of these specialties, certification is time limited, and unless you're grandfathered or grandmothered in, you have to fulfill certain criteria to keep certified in your specialty. So what is the purpose of recertification? I think it's really to ensure physicians provide high quality care throughout their careers, that they're keeping their skills and knowledge up to date. They have the skills of lifelong learning and can incorporate new information into their practices. They're continuously improving their outcomes. And then there's this element of public accountability, which the boards feel they need to be able to provide to assure that the doctor a patient is visiting is truly competent. But it's been very controversial. A series of editorials in Newsweek, really highlighting this whole controversy of the current system of maintenance of certification and whether this is the best method to assess lifelong competence. MOC is not popular. It's probably least popular through the American Board of Internal Medicine. The American Board of Pediatrics is a little bit more progressive. And there are many things that are trying to be done to make this a better system. But right now, some of the issues is really this detailed kind of checking the boxes that has to be done. It's been likened to a grocery store shopping list: 3 non-organic potatoes, 1 sweet, 1 purple, 1 russet, but every third year all 3 must be organic and in reverse order. 13 slices of Swiss cheese, lactose and whole free. 1 bag of spinach expiration is recommended to be yesterday's date. And so, I think a lot of maintenance of certification has become a checkboxing exercise for physicians. I've recently written an editorial towards more meaningful accountability to the public. I think we can do much better in the way we assess lifelong competence, following principles of making it as evidence-based as possible, using some of the things we're doing in undergraduate medical education and graduate medical education related to competency-based medical education, and really to do more, not to sort of checking boxes, but to foster lifelong learning and practice improvement. So let me finish with this whole idea of disruptive innovation. I'm a fan of Clay Christensen, who defined this. He defined it, and the best example is, desktop computers replace big mainframes, even though they started off not quite as good. And, I think there is disruption going on in medical education. And as we think about the future, we need to pay attention to this. And one example is, a new medical school that's being started by Kaiser Permanente with the goal, and in quotes, to train new physicians specifically for data-driven outcomes-based care. And students will be embedded in that system for day one. There is no separation of here's the science, now we apply it clinically. So this is an example of a health system that's starting a medical school. It's not a university. And I think this is sort of an example of how medical education can be easily disrupted. I think the most local example is this new medical school that will almost undoubtedly be started, an osteopathic school in Gaylord, Minnesota, focused on rural primary care. So one of my favorite philosophers is Wayne Gretzky, and I think we try to follow his example when we think about the future of medical education. His famous saying is, "I skate to where the puck is going to be, not where it has been." This is also consistent. I've never wanted to give a presentation without having at least one hockey analogy, having grown up in Canada. And then let me finish with, the other thing about the future of medical education. This is our recently funded, both by the university and by the state, Health Sciences Education Center, which will be on the East Bank where the current Masonic and VFW buildings are. This is a really innovative education center that will be shared with the other academic health center schools. Simulation is a huge part of this new building, as are active learning classrooms. And we're scheduled to move into this new building in December 2019. I think it's one of the most exciting developments that will have happened to our medical school in terms of medical education, and one that will be a reality. And we're now just trying to work with our faculty to teach the skills of what it will take to teach in a building where it's not so much amphitheater lecture based, but active learning classrooms. So with that, I'll close, and I think there's a couple of minutes for any questions. Thank you. Yes.
There was one word that I kept waiting for you to mention, and it means predicting the future, which may make you a little bit uncomfortable. Have you thought a little bit about what this new approach is going to do in terms of physician burnout, which we read about so much? I realize it's new enough so that you can't quote any facts probably at this point, but certainly you must have thought about it.
Sure, and I think physician burnout and medical student burnout, medical school depression has really caught the national limelight, and is something that we think about a lot and pay a lot of attention to. And we have a very active well-being program among our students now, encompassing sort of a whole spectrum of well-being. So trying to teach them at a very young age in terms of their medical education to stay well. And one example, and it's just one of many things we're doing, is there's evidence that eliminating grades in year 1 and 2 helps in terms of well-being and decreasing burnout. And that's something that we've just implemented as a pilot starting this year. Many other examples, but I think something that we need to pay attention to for sure.
Thank you very much. Really enjoyed the talk. The thing that struck me a little bit, and I'm familiar with this through working at AMA and some other places like that. I'm Blanton Bessinger. Most people in the room don't know who I am. But this fixed outcomes variable time. So, a caddy side of me said, well, how long do you get to try? And so forth. Because clearly, although in 1961, I went to med school at Emory after 3 years of college. Now, it wasn't programmed from high school, but, they did this same experiment of shortening it up. And yet we knew if we failed a couple of courses, we repeated the whole year. So there was a real incentive. So can you comment a little bit about how long would you keep trying to train for competency? Is there an endpoint?
Sure, and a couple of points. One is, the test using EPAC is really a two-tailed test. So some students may progress faster, some may take longer to progress. And, so far, everyone has been faster, but it may be related to how they're selected. I think the worst disaster in medical school is you do 4 years of medical school, accumulate 4 years of tuition debt, and then you don't match into a residency. And so what we're trying to do is, at a very early stage, identify high-risk students, and even having hard endpoints, in the first and second year of medical school, where they no longer continue to try and avoid this outcome of, not having, being able to match. So I think that should be part of this whole competency-based education. And part of what we're trying to do with this outcome center is look at predictors of who's going to do well and who's not going to do well. So good points.
Mark, congratulations on what you've accomplished. It's wonderful. I'm questioning the issue of continuing, I don't want to use the word continuing medical education, but lump it together with residency training and post-residency training. Given the fact that so much of healthcare is now going to be based, as you reply, on evidence-based medicine as an ongoing activity, costs are going to be related to choices of those diagnostic and therapeutic procedures. What is the magnitude and nature of the linkage of medical schools per se with the realms of education that continue throughout a professional's life?
Nice to see you, David. And yes, so I think we need to connect these as closely as we can. And I think data is one part of this. And, and then it's also teaching the skills of lifelong learning. So what students learn in medical school is really how to learn for the rest of their lives. And that should continue from GME to CME and it should be part of, their DNA of, how do I learn throughout my career? So, and you're right, the models of reimbursement and care are evolving and evolving quickly. So I think it's incumbent on us to teach those to our learners.
It's 8:30 now, and I want to thank Dr. Rosenberg for great grand rounds, and also congratulate Dr. Youngki Kim one more time. Congratulations, Young. Thank you.